Good morning, members. Now it's time for the meeting, and we have formed a quorum. This is the first meeting of the ESC for this session. I would like to welcome you all. Now, today we have 5 papers to discuss. Before the meeting, the government submitted a paper numbered ECI 2018-1910 for members. And this paper is a summary of the latest changes in directorate establishments approved since 2002 and the changes to the directorate establishment of civil servants in relation to the 5 discussion items on the ESC agenda for today. I would like to remind members that for today's discussion items, if you have direct or indirect pecuniary interest, please, in accordance with Rule 83A of the Rules of Procedure, disclose those interests before you make a speech. And also, please pay attention to Rule 84 of the ROP. If you, that is the requirement about voting with direct pecuniary interest. Now, the first agenda item is inviting members to recommend to Finance Committee the creation of the following permanent post in the Department of Health with immediate effect upon approval of the Finance Committee. That is 1 consultant. Now, this would ensure that the family clinics' efficiency will be enhanced. On 19th of March 2018, the government consulted LegCo's Public Service Panel on this item. We have in attendance today the following government officials: Ms. Amy Wong, Deputy Secretary for the Civil Service; 2, Dr. Constance Chen, Director of Health. The chairman of the PS panel, Mr. Gary Fan, is not a member of the ESC and he's unable to attend today's meeting. I will briefly tell members what has been discussed at the PS meeting. The PS panel at its meeting on the 19th of March 2018 discussed this item. Members in general support that the proposal be submitted to the ESC for deliberation. At the meeting, some members asked, how will this proposal enhance the medical service offered by the families' clinics? And the government's replied that for the consultant doctor of family medicine, it will be responsible for the oversight, planning, and quality assurance of families' clinics. Now, because family clinics are expanding and the workload of their doctors has been increasing. Moreover, risk assessment and management programs is now being provided to diabetes patients. As a result, the workload of the present consultant has exceeded what he can afford. So now they are proposing to increase this post so that the quality of the family's clinics can be assured. Mr. Chong Kwok-fan, thank you. For the increase of family clinics, I think there is a need, and of course, we need someone to take care of these new clinics. So I support the creation of the post, but I have a number of questions. First, well, concerning the organizational chart in the attachments, there are different work areas. I think, yes, we need a division of labor. Now we will have 2 consultants. The first one is responsible for Hong Kong Island and Kowloon. The second one is responsible for NT. At the same time, they have to do administrative work. And for consultants 1, he's also responsible for training and administration. As consultant 2, he's responsible for risk assessment and management. So why can't it be more focused? For example, for consultant 1, maybe he should be responsible for all the clinics in Hong Kong, Kowloon, and the NT. So he's solely responsible for the works of clinics. And the consultants too should be responsible for administration, education and training center in family medicine, and RAMP, a risk assessment and management program. So why can't there be a clearer division of labor? Why should both consultants be responsible for managing clinics and doing administration at the same time? I think the portfolio would be too wide if you have such an arrangement. Dr. Chen. Thank you, Mr. Chung, for your question. When it comes to the division of labor, we have already taken all this into consideration because for these two consultants, they are family medicine specialists, so their clinical experiences are very important. We hope that the consultants can contribute their expertise to these clinics. So that's why we've divided the work by regions. Now, for consultants one, he's more experienced, he's more familiar with the operation aspects, so that's why he's also responsible for training and RAMP for training. And as for consultant 2, because RAM is relatively new, so he'll be responsible for that. So we hope that both consultants will take care of clinics and also they would have other duties. For consultants 2, when you hire him, do you hire him from the private sector or is an internal deployment? Well, for our existing doctors, many of them are actually eligible for this promotion. So this will be an internal promotion. Just now, the director told us that it is hoped that both consultants can be involved in clinic works and at the same time they can also do administration. When I look at the main duties and responsibilities in enclosure 3 and 4, it seems that many of their duties are duplicated. For example, they are responsible for the long-term planning strategy and service development. So back to my original question, their duties will be overlapped and the workload will be heavier as a result. Dr. Chen, for professional development and quality assurance, all clinical units would have to take care of that. So even for other doctors working at hospital levels, they have to look into this. Now for this new consultants family medicine 2, he will be more focused on the new program, that is the risk assessment and management program, because in the department it is a new program, is to target diabetes patients. So he may have to do more because this is a new program. And there is also an element of professional development and quality assurance in it. Next, Mr. Holden Chow. Thank you, Chairman. For creating this post to take care of such a big team, and in particular, we know that Cyclone Families Clinics is being planned and there will be additional work. So I support that this post be created. But I have some questions. In the paper, from paragraph 7 to 9 is mainly about RAMP. And according to the paper, at present there are over 5,000 diabetes patients attending family clinics. And for this program, it is hoped that better service can be provided to the patients. And if the conditions improve, then they don't have to use the family's clinics so frequently. There will be multidisciplinary staff forming a team to take care of this program. So can you tell us about the manpower in this multidisciplinary team? For the multidisciplinary team, we have nurses and other allied nurse health professionals. In 2018-19, 8 posts will be created, and for 2019 to 20, 6 additional posts, in total 14 posts. And we expect to provide services to 3,000 diabetes patients. So for this 14 staff, they will be taking care of 3,000 diabetes patients. So for the staff, or for this consultant, is he just the administrator, or for this 14 staff members, will they be doing the frontline work, or will they be just administrators? And for the new consultant, one of his major work or tasks is to plan and develop RAMP. That includes putting together clinical protocols, etc. As for the multidisciplinary team, there are doctors and dietitians. For diabetes patients, they need to see a doctor, but the doctor may not have enough time to provide details to the patients. So nurses, dietitians, ophthalmologists, etc., they can also help. So with this new team, the patients can be taken care of more thoroughly. So it's not just about consulting a doctor. Nurses will be explaining to them in greater details, and dietitians will also be helping them. So for this type of assessment and management program, we have learned from overseas experience that they are very helpful to diabetes patients. I think it's good to have such a team. But when we look at the number, we only have 14 people serving 3,000 patients. So would they also have a very heavy workload? Now, this is a very good plan. And diabetes is a disease that may cause many different complications. So why did you choose diabetes in the first place? Would you consider doing the same for other types of diseases? Thank you, Mr. Chow. Well, we are serving 3,000 diabetes patients. It doesn't mean that in the initial stage we will provide full services to them immediately. So it's like we're doing it gradually. It may take about 2 years at least before we can offer full services to 3,000 patients. These patients will be coming back for regular assessment by the professional team. Now, why did we choose diabetes? Because in overseas countries, they already have very rich experience in this, and also diabetes patients may also have high blood pressure and other problems. The complications may affect their body seriously, and literature has shown that such kind of management program is very useful. Now, for diabetes patients, they may have high blood pressure and high blood fat content. So by taking care of them in this way, it would be better. Now, after operating for a few years, we will try to expand the program to cover other diseases. Mr. Yu Siwing, I support the creation of the post. You have given us some data. In the past 10 years, the number of civil servants attending family clinics has doubled, and you are now opening 2 new family clinics, and the total number of attendants will increase to 352,000, and in Changquan there will be another new clinic. So you have all these plans. So there will be 2 new clinics very soon, and then another additional clinic later. Can all these clinics meet the requirement of the civil service eligible persons?
Apart from the Changguan families clinics, would you consider increasing other families clinic as the demand is increasing very fast? Do you have considerations for that? When this new post is being added, would he participate in the planning and establishment of other families clinics, or is he only doing consultancy work medically? You need experienced doctor as well as family medicine specialization. This is a specialist doctor. I believe in his expertise. However, for the planning of families clinics, what are the considerations you have in mind when seeking such a consultant? What are your criteria for assessment in his recruitment? Thank you. Well, perhaps I should speak on the demand, the meeting of the demand of such expertise. For the CSEPs, the requirements, we are doing it through our department as well as the hospital authorities. Apart from families clinics, the hospital authority is also looking at the service provided to the CSEPs. We have one in Sai Kung families clinics. It will have 2 consultation rooms opened at the end of the year. And then there is another families clinic to be opened in Changguan. So we have 2 families clinics in the pipeline. If we have any other new buildings being built, we are seeking appropriate sites in order to have them established there and increase the number. The Director of Health, well, the consultant that we are seeking, if we have to ask that he has a specialization in family medicine. So such is a criterion that we would apply. As for the consultant, his function in the preliminary stage is introducing the ramp, and he's also going to take part in the establishment of the Sai Kung Families Clinic as well as the Changguan Families Clinic. So his task would include planning as well as applying his specialization skills. Chairman, so you are assessing him on the medical specializations, or are you also taking into account his planning expertise when you are recruiting the consultant? Director, the promotion of doctors to the consultant level, apart from the specialization or professional qualities, would also take into account his planning ability as well as his leadership. Dr. Cheng Lai-wan, from the document, we can see that we are going to have 5 families clinics as well as 38 consultation rooms. If we are going to open another one in Sai Kung, we will have 6 family clinics. Well, the Sai Kung families clinics have 2 consultation rooms. 38 plus 2, we are going to have 40 consultation rooms. However, you are saying that we have 6 families clinics and 44 consultation rooms. What are the remaining ones? Where are the remaining ones? It will be in the Fanning Families Clinic. We don't have doctors now for these 4 consultation rooms. So there are 38 in operation, and when the SciComm is being opened, there will be 40 in operation, whereas the 4 in Fanning will not be in operation. Let me clarify. In the organizational chart, we have consultation 1 and consultant 1 and consultant 2, and both are families medicine specialists. The duties they both have are related to planning, whereas operations are being done by other doctors. Well, of course, you need more management personnel when you have more clinics. Now, as for planning and development, these 2 consultants are being responsible for different consultation rooms. Well, would it happen that they have different plans or different methodology in planning and development? Thank you, Chair. With respect to planning, the 2 consultants will be in charge of the new ramp, as well as the SciComm Families Clinic, as well as the upcoming Jiangguanou Families Clinic. They will also draw up the guidelines for diabetes patients. For instance, for high-risk patients, what are the guidance for referrals? As for consultant 1, he would be in charge of the orientation and training, as well as quality control. For instance, we have clinical auditing, and these are overall management. So there is a division of labor. The new consultant will be in charge of the new clinics as well as the RAMP, whereas the consultant 1 will be in charge of the overall orientation as well as the professional training of personnel. Well, when we speak of planning, so for these 6 families clinics, if you have different consultants taking care of planning, you might have different results. So that is the reminder. So we have to be clear on that. The consultant 1, he will be in charge of the for clinical records, in charge of the records. Mr. Xiu Ka-chun, you are now creating a post to increase the level, to raise the level of families clinics. Of course, I will fully support the diabetes system. I am also one diabetes patient and have such an experience for the over a dozen years. Diabetes is not my personal problem. It is a worldwide chronic disease. There are about 700 to 800,000 patients in Hong Kong with diabetes. And it is a problem of worldwide concern. And we also know that there might be 1 in 7 deaths, one death in 7 patients. So I think that it is only important that diabetes should have professional teams taking care of them. We are talking about a 14-member strong team to serve 3,000 patients. However, well, you are serving only civil service, but there are quite a sizable number of patients. But you are talking about this 14 team are taking care of 3,000 patients. The salary of this consultant is about 2 million, and if you take into account other benefits, it will go up to 3 million. If you don't recruit this consultant, you can use this money to recruit more specialized doctors. Why is it that you have not chosen this alternative with better use of resources? We know that there are many theories for the treatment of diabetes. This is a diet, is concerned with diet, sports, medicine, etc. Do we need to have such a high-paying consultant to take care of that? Director, this consultant post, his major tasks is to introduce a ramp. However, it is a teamwork, and it will include nurses, dietitians, and optometrists. This consultant is supervising for the overall development because this is a new program. Well, this consultant is taking care of the development of program itself. For instance, referrals and the whole procedure of treatment. The flow of the procedure, apart from supervising the ramp, he's also going to supervise new families clinics, for instance, the Saikong Families Clinic. The patients now being treated there in families clinics, if there are serious cases, the consultant will also take part in giving advices. So he's not only taking care of the ramp. Diabetes is also a problem, but also a mental problem. We are talking about diabetes patients, but you should also take care of the mental health of the civil service. What have you to add, Director? We agree to that. So we have added 3 clinical psychologists in the past years. How many? I can't remember when did we added these 3 psychologists in families clinics. So you are talking about we are really short. There are only 3 psychologists taking care of the entire civil service mental health. And when did you added the 3? Because my family's clinics should not only take care of physical health but also mental health. Mr. Chen Chi-chuen, as an employer, the government has the duty to provide medical service to civil servants. This post is to assure that the CSEPs can enjoy quality primary health care. We know that there are special medical benefits. They have priority in public hospitals for the civil servants, and they can also use the families' clinics. Well, the eligible persons are mainly the family members of the civil servants. However, the families members do not include the same gender partners. That is to say, the partners who are married abroad or come together abroad, they are not eligible to consult the family's clinic. We know that we have judicial review on this matter. This is the Leung Cheng-kong's senior customs officer case. It was lost, and then it has gone up to the High Court and the Appeal Court. Now, I'm not commenting on that or asking for response.
I just want to make a point. The government's lost in the court of first instance, and now it says that if the other party wins, then they are already ready for new arrangements. So let's talk about a policy, not this particular case. For families clinics, we have 5. One in Chai Wan, Wan Chai, Hong Ham, Chai Wan Fanning, and there will be a 6th one at Sai Kung. And one is being planned, that is the Zhang Guan Ngou. So I have these questions. When you find sites for such clinics, will this new post holder be involved in looking for sites, and will he be involved in the planning of new clinics? Now, I want to ask this question. Look at the distribution. Now, after Sai Kung, we will have a Zhang Guan Ngou clinic. They belong to the same district, that is Sai Kung district. But in Yuen Long, Tuen Mun, Tin Shui Wai, you still do not have any families clinics. Civil servants may have to go to Chun Wan for the service. So what is the distribution policy? I think the government has already noticed this, but they might have encountered difficulties. So for this post holder, will it have the responsibility to look for more suitable sites? How about NTA West? For this new consultant, it will be involved in planning. So when it comes to looking for clinic sites, there are some limitations. When we look for sites, the consultant and his team can provide the government information. For example, what services they will be providing, etc. So they will be providing information to the headquarters, and the headquarters team would have to look at available government sites. So the consultants will be involved in providing information, but when it comes to deciding on which sites to be used, it may not be his decision. So we will have to look at the government's available sites. So what you mean is that you need available sites. When there are suitable sites, you will open new clinics. So how about NT West? You don't have any sites? So if there are sites, you will be building new clinics there? In Sai Kung, the clinic is of a smaller scale. There will only be 2 consultation rooms. As for the Zhang Guan Ngou clinic, we hope that it will be bigger so that it can take care of more civil servants. As for NT West, we have a Fanning Families Clinic, and there are 10 consultation rooms, but at the moment only 6 rooms are being used. But we hope that by having the Fanning Clinic, we can take care of the civil servants living in NT West. Mr. Ho Kai-ming, we support the creation of this post. So for civil servants' interest, I think it's just like a company's welfare. Now, civil servants have their own clinics. I understand that. But when it comes to different specialties, there are problems because general practitioners or family medicine doctors cannot take care of all types of disease. So if it's about a certain specialty, the civil servants would have to go back to the public queue. I remember I was fighting for a CT scan machines for the patients, and we did a lot of work. So for family clinics, yes, they can provide primary health care. However, when they have other diseases, they have to go back to the public queue, and they will be fighting for resources with the general public. So my question is, can there be public-private partnership so that civil servants in need can go to private hospitals for treatment, and they can get their medical fees rebate from the government? Now, this is a new post. Can this post holder also review the policy so that civil servants can go to private hospitals? Why must they go back to HA hospitals? If they are allowed to use private hospitals, then it will help them treat their diseases faster, and they can go back to work faster. And also, this new post will also take care of professional development and quality assurance. I think that would also help. Now, for PPP, we've heard the views of civil servants. At the moment, we still hope that they can use HA and DH services. We will continue to make improvements in this direction. Now, you hope that there will be improvement, but what are the reasons for your hope? I don't think you can justify your hope. Now, are they providing the best service, the cheapest service? Why do you want them to use the HA service? HA is independent from the government. It's an independent institution. Now, for HA's services, they are very comprehensive. So for the civil service eligible persons, I think the services are very good. So we hope that more specialists and other services can be provided to civil service eligible persons in the HA hospitals. Yes, that's about primary health care, but how about specialty services? They still have to wait in the long line with other civil servants. Now, I was talking about the CT scanner that I was fighting for because they didn't have it. Well, CT scan is a very basic medical equipment. So for this new consultants, will also conduct such studies so that the services can be bettered. At the Prince of Wales Hospital and Queen Mary Hospital, there are specialist services for civil service. Yes, that's what I fought for. So we will continue to work in this direction. Now, HA has his 10-year hospital redevelopment plan. So we're fighting for facilities which are catered for civil servants only. But all these services can be found in the private healthcare market. So why don't you allow civil servants to go to the private market to seek such services? We have been talking about this for a long time, and now we have this new consultant. Can he carry out study in this area so that he can explain to us why civil servants must go to HA hospitals? For PPP, DH is one of our healthcare providers. So for this new colleague, he will not be looking at the area you asked about. Next, Mr. Wu Chiwai. Thank you, Madam Chair. For DH, it coordinates all the outpatient services. And then for the general public's outpatient services now is taken care of by HA, and as a result, there are families clinics. But if you look at figures, for families clinics, we're now looking at the number of attendances. In the initial stage of family clinics, each year, the total number of attendances was 168,000. And now with the new clinics in 2017 to 2018, the new figure, that is the total number of attendances, was 297,000. If you look at the average attendances, actually the number has dropped. That may be good. Maybe if the civil servants are now healthier. However, if you look at it from another angle, there is a huge demand for public healthcare services. For outpatient services, we needed very much so. That's why we have been asking DHA to improve its services. So there is a huge gap between HA service and family clinic service. Now it's very difficult to open a clinic. So clinics should serve more people. Maybe such clinics should provide services to the general public as well. In the past, clinics did that, and they had two queues, one for the public and one for civil servants. So is it the government's policy? That is, you must build clinics for civil servants, or can you, with limited resources, do it in another way? That is, in a clinic, services can be provided to both the public and civil servants so that resources can be better used. And also it is pointed out in the paper that these clinics will also be providing services to diabetes patients, and DH is responsible for that. Now you have such a service for civil servants. So while you are providing service to chronic patients, can the new consultants also help to plan primary services like this for the general public? And that should also be one of the tasks of the DH. Thank you. For families clinic, we adopt a two-pronged approach. That is, families clinics and HA outpatient services would both provide services to civil servants. I think for family clinics, the utilization rate is high, it's 99%. So we are making the best use of our resources. In the future, we will have Sai Kung Clinic and Cheung Kwan O Clinic. Well, for families clinics, what's the average consultation time? For HA doctors, I think they can spend 2 or 3 minutes on one patient only. So how is it compared with the family clinics doctors? I do not have the data in hand. On the average, one consultation room can serve 8,000 patients per year. So each day is about 30 patients. Because this is a family medicine approach and is more comprehensive. However, for HA consultation rooms, they do not have such a privilege. I support that this permanent post be created, that is consultant 2. When I look at the figures from 2008 up to now, well, originally there were only 3 family clinics. Now we will have 5 and even 6. For the Cheung Kwan O families clinics, I've looked at the timetable.
呢一位新
This new consultant will be in charge of the management as well as the planning of this clinic. As for the major tasks and responsibilities of this new post, he will have treatment of chronic diseases. What sort of chronic diseases will be included? And there is also the ramp. These are two separate matters. The ramp will focus on diabetes. But however, we know that there are a lot of heart diseases patients in Hong Kong. I'd like to know whether in the family's clinic would there be a risk assessment for heart diseases, and also the nursing care for after stroke patients. This consultant also needs to do some clinical diagnosis. Well, what is the time? How do you divide up the time between the duties of planning and also clinical consultation? So we'd like to know that he has to take care of administration, planning, as well as clinical consultation. So what is the distribution of time for him? Well, for the director for the family clinics, we will have one family clinic in Changquan-O. This building will be, the work will start in 2020. Such is the schedule now planned. Well, as for chronic diseases, we have picked diabetes first because there are lots of complications due to diabetes. Apart from the control of diabetes, it might affect the heart, the blood pressure, and also the failure of kidneys, as well as veins and arteries. We have chosen diabetes. We feel that much benefits can be reaped from such experience because we need to manage diabetes to control complications. First assessment will lead to referrals to nurses, optometrists, and dietitians. The doctor will take care of the referrals. We will have assessment classification of different levels. He will plan what specialists you need to see, in what frequency. So it is a management of the flow of treatment. We are going to start with diabetes, but we also take care of high fat, high sugar in the blood. So we hope that such experience from diabetes can be promoted to other chronic diseases. Well, for this consultant, he needs to start with this ramp. So most of his work will be the organization of the team of ramp, as well as setting out the clinical guidance of ramp. So he will have 2 sessions of clinical consultations in the initial stage. As for the diabetes assessment, you need to choose your patients. So what is the progress you have made? According to our estimation, there are about 5,000 diabetes patients in the family's clinics. And when we have this professional team set up, we will be serving 3,000 diabetes patients. And in the family's clinics we have now, we will refer patients to this professional team for assessment. And for these 3,000 patients, we need to have 2 years before we can cover all 3,000. Mr. Tam and Ho, Jeremy Tam. In page 5, you have F, Development of Electronic Clinical Information Management System. I'm surprised that we are still using paper for records. In April this year, in the health panel, we talked about the raising of the level of information and papers. And you have also had a consultant to look into the matter. You said that the records are scattered and they are functioning on their own. Now, why is it that you are doing it yourself? And why is it that you have not adopted the system of the HA? Why should you spend so much time and energy on setting up another one? In April, in the panel, as well as if we look at the records of that meeting, as well as paragraph 13, it would mean that you were trying to set up your system and not adopting the HA. The last sentence, you are keeping continuous liaise with the hospital authority. Do you mean that you are still wanting to set up your own? Our electronic records, it is true that in the past it had been rather scattered. That is why 2 years ago we had started a consultant study report on this matter. And so the result is we need to have a special setup in order to set up our electronic health records. Now we have public health part and also the clinical part. Well, in the past, part of our records have been already done electronically. For instance, the making of appointments. We understand that you have done such work. My question is, why is it that you have not followed the HA system in the beginning? Well, that would have different structures set up. Well, but I don't know for what reason you have not chosen the HA system to have the same system. Response. We have different units and we have different development. And after this consultant report for the clinical part of records, we have invited the HA to provide us with technical support. That is, we have now such an orientation. In the past, we had a different idea. So you would say that in the past you wanted to go on your own and not adopting the HA system. When did you have an idea of your own system, and when have you decided to adopt the HA part of the HA system? Well, Chair, this is not directly related to Families Clinic. So we'd like to know the electronic system. Are you going to connect with the HA system? Response. Well, when did we have such an idea? Apart from since 2012, when I came into office, I looked into the matter. We had this consultant report, and the result is that we needed to have a coordination. That is why, for clinical records, we have invited the HA. Question. When are you going to connect with the HA system network? Well, we have different units. We have family clinics as well as other units. This is a long-term work, but it would need several years. Mr. Tam, you can go for the second round. No, I don't need the second round. Dr. Pierre Chen, I'd like to support the creation of the post of consultant. I have two comments. First of all, it has been said that the Families Clinic provides, on the whole, good service, which is true. Now, of course, continuous efforts have to be made. As for the dental service provided, to the civil service. It is quite good service. However, for the other members of the public, I think that more can be done for them. We have good medical service and benefits for the civil service. How do we enlarge it to the general public? Well, we still support the creation of the consultant. As for the electronic clinical records, I remember that there was an application for some funds to allow the HA to renovate this system. In the last dozens of years, we understand that the records of the health of department and the health records of the HA, they are not connected together. And I know that in the future there will be a great change. For the outpatient service of the family's clinics, well, they ask us, the attendees ask us, do we have records of what is being done by the public service, which they also consulted? Well, the civil service would like to have this connection so that they can also have these records. They are not quite happy when such records are not made available. But the family clinics say that, well, we don't know about them. The HA has a very well-connected network. However, not for the health department. So we hope that in this question, we know that the HA also passed through a difficult period where you have to switch from paperwork, which has been always the habit. So you need to transfer from paperwork to the digital work. Well, the HA has overcome that, and it has proved to be very convenient. So I hope that this new post will be able to help other colleagues to transit, to go from paperwork to digital work. Chair, can you promise that this consultant can promote the connection of family clinic records with HA records? Well, with this consultant 2, the consultant 1 can have more energy and time to promote this connect. Mr. James Toh, I will have a follow-up question. Well, of course, this has to be done, but what is your schedule? Do you have an idea of the time needed? Response, you are talking about the electronic system? Yes. Earlier, we have obtained funds to set up a team to establish such a system. I can't recall the exact time when it is set up. Are you talking about 2 or 3 years? Well, it should be 3 years. We have a lot of clinical records. Well, I have 2 points of view. It is a matter of benefits for the civil service. Well, there should be better work done with development envisaged. Secondly, since government is providing the service, improving the efficiency will have other benefits for the electronic records. You will save up on the paperwork and the staff involved. Some basic questions. When you provide such a development for the medical service of the civil service, are you, well, for salary, you need to have investigation of the general public's salary. Do you have such a system for your task at hand? For instance, what are the benefits provided by the private market in the matter of medical service? Because they need to have medical service to attract employees. Now, if you don't have the information now, you can provide later. In fact, the civil servant is also member of the public, general public. If he goes to the HA service, what is the difference in the service provided by families, clinics, and the HA? For instance, the time that he has to wait.
Some members say that now you're providing such a good service for the civil servants. Can you also do the same for the public? Well, but there is a difference here because you are an employer. You want to attract people to join the service, and you also want to retain the present civil servants. So I don't think it can be compared in that way. But of course, I hope that you can make more improvements. Well, my questions can be answered in writing later. And in paragraph 10, you say that you will be enhancing supervision. You will be hiring more than 20 people, so that's why you need another head to supervise. So for HA, is it the same if the number of staff increase by a certain number, then there will be one more head? So the proportion is better at family clinics or what? And another question, after you get this new consultant, things will be better. And originally, some civil servants would go to the HA clinics, and now they will come back to families' clinics. So how much improvements can be made? So if she can answer me now, I would welcome that, but also the question can be answered in writing. I think you've asked a lot of questions. Which questions can be answered right now? Director? I'll answer the questions concerning proportion. Under HA, there are a number of specialties. Well, and for consultants, the social disease, the payment is 14:1. For lung disease, it's just another ratio. And for child's assessment, 1:23. If we do not have this new consultants, and the ratio is 1:45, after adding the new consultants is 1:23. I mean a comparison between families, clinics, and HA, not consultant to the number of subordinates. Okay, please give me the answer later in writing. Dr. Kokake, I support the creation of this post. However, I cannot solve all the problems. When the HA was established, civil servants service was also included in HA. That's not fair. HA should try to provide fair and equal services to all citizens. But now civil service are also served by the HA, so there are two queues. And as a result, many conflicts are created. So if you are doing a good job for civil servants service, then the public would query, how come the civil servants can get better service? Yes, this is not a theme we're talking about today, but this is a long-term problem that awaits the government's solution. Now, for families clinic, the doctors would only take care of 20-something patients a day, but for HA clinics, more than 80 persons. So I think all the citizens would want to enjoy the family clinics level of service. I don't blame doctors. Most of the doctors can only spend 5 to 7 minutes with a patient. Otherwise, the other patients would have to wait for a very long time. So this is a mess, and I think it's the government that created this mess. So in the long run, how do you improve services to the civil servants? If you still adopt this method, you can never solve any issues. Just now, I didn't like the director's answer. Now, if I live in a faraway place in NT, for example, Tinshui or Yunlong, and you tell me that I should go to Fanning for a doctor, well, it doesn't matter. You can take a bus for 2 hours, and eventually you see the doctor. I don't think this is something you should say to the civil servants. So for some civil servants and dependents, if they cannot get, I don't think they are getting proper services. So can you tell me the cost of each consultation? For DH, I think it's $300 to $400. And a doctor will see 80 patients per day. So for you now, I think it's $1,600 per patient. So if you provide them with subsidy, then they can go to a nearby doctor. Why don't you consider that? And also the biggest difference between HA and DH is that in HA, if you want to be a family medicine doctor, it's very difficult for you to be promoted. So for doctors with family medicine qualification, can they have a better promotional path? For example, can they become a deputy consultant? Well, can you give me the number of doctors with family medicine qualification but are still waiting for promotion? And also, why can't you give the civil servants a subsidy for them to go to private doctors? Now, for the NT families clinics, we have 2, one in Tsuen Wan, one in Fanling. Just now, we said that Fanling is a newer one. Well, if a person lives in Tin Shui Wai, it's very far away for him to go to both Tsuen Wan and Fanling. But he has a choice. If you are sick, what would you do? I just want to explain that there are 2 clinics in the NT. If you have a fever and you live in Tin Shui Wai, what do you want to do? If you or your family members are sick, do you want to go downstairs for a doctor or go to Tsuen Wan or Fanning for a doctor? I think it's a personal choice. Maybe he's used to going to a certain clinic. So if you are sick, you ask him to take a bus for 2 hours. Fanning belongs to NT East. Please answer the other questions. Just now the member asked about PPP and why can we consider that? This involves a very significant policy change. At the moment, we do not have the intention to provide this kind of service. Can you give us figures? How about the cost and the promotional path? As for cost, I will give you the answer later in writing. Now we have 1 consultant to 45 senior doctors and doctors. That is the ratio. So with 1 more post is 1 to 23. So a professional qualification, later on I'll answer you in writing. How about career path? That is very important. Otherwise, it's very unfair to them. Okay, after the meeting. Next, it will be me. I have to declare interest. I'm a retired civil servant. I'm also using your clinics. Well, according to the official's answer, there are not enough doctors to open all the consultation rooms. So will you have enough doctors in the future? I think I've heard that it's very difficult for DH to recruit doctors. We are actively recruiting doctors. In the past years, well, from 2015 to 17, there were 7 recruitment exercises. There was 1 in April this year, and now we have some newcomers. As for DH, professional development and quality assurance department, now we still need 4 more doctors. We will continue to recruit. And some doctors are qualified with limitations. That is, those doctors who are qualified overseas and they are not fully qualified in Hong Kong. We are now considering them. For Fanling and Shengshui, there are discipline forces quarters. So when can you add doctors there? Well, we will have another recruitment exercise in October, so we will look at the actual situation. Just now, many members asked you about families, clinic staff, and working hours, and they are compared to HA service. So Mr. James will ask you, how will you benchmark? Would the government agree that civil servants' welfare should be compared to the welfare of big companies in the private sector? Well, many companies or corporates would take out medical insurance for their staff. Now, but the population is aging, so civil servants and their eligible dependents are also aging. And also for discipline forces, it's difficult for them to go to families' clinics during office hours. So how about taking out insurance for them? Or can you better the arrangements with HA? Well, some civil servants asked us if we would consider buying insurance for them. But for the insurance in the private market, there are different coverages and limits. So they would not be better than the services provided by family clinics and HA, and we also have to consider our resources. So we will continue to provide services to the civil servants through HA and DH. Well, HA is a huge organization, so how do you compare your service with theirs? I think HA also has staff clinics for their staff. So their staff will have priority. I'll have to find out more information before I can answer you. I think some civil service unions have put forward a suggestion of the government buying insurance for them so that families, clinics, and HAs can have reduced their burden. Well, some trade unions have shown us insurance policies lately. We are now scrutinizing them. But this is a major policy change and it involves huge resources, so we have to be very careful. Second round of questions, Mr. Chung Kwok-pan, 4 minutes. My question is similar to yours. That's about manpower. Just now, we were told that for Sai Kung or Tseung Kwan O Clinic, I think there are 10 consultation rooms and you can only open 6 rooms because you do not have enough manpower. I think this is a long-term problem. Just now we've had some figures. For families clinics, a doctor only sees 20 to 30 patients a day, but in HA clinics, a doctor would have to see more than 80 patients a day. So will you attract HA doctors to go to your department instead? because the work pressure would be lower. This is question number one. Second question about diabetes. It seems that there are many civil servants who are suffering from diabetes, and for heart disease or cancer, that's also an issue. Do they discover their diseases on their own, or do you provide health checks for civil servants on a regular basis, and then you discover certain diseases in them, and then you provide the follow-up services?
For the first question, the vacancy is about 9% in our staffing. So there's no attraction from the HA. As for the ramp, for the we have transfers of patients. Well, for these diabetes patients, for instance, when they had examinations of urine or blood tests, they already know that they have diabetes. When they have consultations with us, we have also confirmed that. For cancer patients, if we have suspected cases, we need to transfer them to other specialization clinics for assessment. I have a follow-up question. For these family clinics, they provide special service for civil servants. As for the HA hospitals and clinics, they have one queue for the civil service. Because, well, if you have family clinics, new family clinics, would it help to shorten the queues for the HA establishments? If it is so, would you have more time and space for the general public? Well, it is a personal choice to go to the family's clinic or to the HA. If we can have more attendees for the family clinics and can also help, then we are glad. Well, you are opening more families clinics so that you are providing more local service for civil servants, which means that you may have diverted some civil servants to your family's clinics. Do you have statistics? Would it help the general public consultation of HA establishments? Well, the chair, can you assess the impact so that that will help reducing the number of attendees in the HA? Well, we look into the matter. We have whether we have such statistics that Mr. Hu Jiwei. We have now talking about the DH shortage of manpower. Now, can you tell us, in the past decade, doctors in the HA, what about their shortage, the vacancies, and what about the losing of doctors? You're talking about the HA or the DH? I'm talking about the DH. From what I've heard, we are fighting for doctors because we have a general shortage of medical personnel, and you go from one pool to another pool. What are the efforts made by the DH so that we can improve on the losing of medical personnel? I hope that you can provide us information before we go to the Finance Committee. But of course, if you can give it to me now, it's all the better. Now, of course, we need to have good fringe benefits for civil servants. Theoretically speaking, apart from families' clinics, the civil servants can also go to the HA establishment. They can queue up for their own queue for the service. Opening a family's clinic is not easy. It involves several policy elements. Since we have families clinics, there may be vacancies. Why is it that family clinics operations should be in the Department of Health? Why is it that family clinics are not under the HA so that you have an overall management system? So that these hard-won resources, such as family's clinic, they serve the civil service. If you place it under HA, if there is any remnant resources, if you put it in the HA, they can be used by the general public. While in the family's clinic, you have family medicine. That is a prerequisite. That is to say, the doctor has to follow this patient as well as the families. So they will follow the patient for 5 to 10 years. So very often a doctor follow the same patient through until retirement. But what about in the family's clinic? Is that such a case? Well, otherwise, the family's clinic have a lot of changes in doctors. If there's such a case, this family medicine idea would not be well implemented in family clinics. In 2015 and 16, it's about 8%. And the rate went up to 10%, and then it fell to 9%, and then in 2018 it's 9% as well. Family medicine is a comprehensive training. Even though we may not have the same doctor, which is for every time, for every consultation of the same patient. This is ideal, but it may not be able to be ensured that the patient will see the same doctor all the time. Apart from the same doctor, there is also the clinical record that can help. So very often, when the doctor, say for instance, for the influenza, the doctor will just treat the influenza. However, for family doctor, they would ask about his general health state, not only the specific case being in search of treatment. So in the family records, the family doctor would go for a comprehensive treatment. Why is it that the family clinics, are not under the HA? Response: the path that I'd like to follow is a special service for the civil service, so that it can be separated from the general public. They don't fight against each other. Now, whether this is being provided by the health department or by the HA, there's not much difference. The most important thing is that the service provided is for the benefit of the civil service. Well, what would like to say that we can have the families clinic that could be able to serve the civil service as well as the general public. It is a good use of public money. Response: we don't want to create the impression that you are fighting for resources. But that's being the case now. You have 2 queues now in HA. So we would separate them in future as much as possible. So you can go for the second round. Mr. Olohin. I'll follow up the question from Mr. Wu Jiwei. If you really want to separate the 2 systems, You are now using a family's clinic to provide service for the civil servants, and you don't want to create an impression for fighting for resources. However, I don't know about the information or material that you are going to provide to the Finance Committee. Well, can you give us information about the priority queue statistics under the HA for the civil service? In fact, how can you promote the use of families clinic and instead of the priority queue? Now, for your policy, if you don't use the priority queue, such slot will be given to the general public. Now, generally speaking, if you look at the tables here, there are several places where such, for instance, for Yunlong and Tianshui Wei, Taipo, and Zhangguanou, Shanxuibo, the general outpatient service is very congested. The demand explodes. Now, the new consultant, is he going to confirm the current system? Mr. Wu Jie is saying that the remnant resources could be used by the general public, but that is not your idea. You are going to separate it as much as possible, and you are going to confirm the family's clinic service, whereas the general outpatient queues are so long. The queues are so long that you cannot meet the demands. What you need to do is to release part of the resources of the family clinic for the general public. As I said, if you live in Tianshui Wei, you go for the HA establishment. The queues are too long. So response for the family clinic, we have 300,000 attendances. If they are not being taken care of in family's clinic, they would go to the HA. They would have gone to the HA. So in such a way, the family's clinic have reduced the pressure of the HA establishments. If we have another one in Sai Kung, it will be convenient for the civil servants as well as the family members to go to Sai Kung for consultations, and that will also help to reduce the pressure for HA establishments. For the priority queue for civil service, if it is not being fully used, it will be released for the general public, so there will be no waste. Well, I understand there's no waste, and that is also a policy. However, my point is, can you tell us your clear direction that you're going to take for the places where you have no where your demands are not met? You are opening family clinics, and you are not fighting resources with the general public. Any other suitable site will be considered for further increase of families' clinics. Mr. Chu Hoi-tik. First question. The people that are qualified to go for the family's clinic is the CSEP. For Note 1, CSEP consists of other persons who are eligible for civil service medical benefits by way of their terms of appointment. How many are they? These are civil service appointments. Who decide whether they are eligible for the family's clinics? Let me have a follow-up questions. The response from the government says that the point is to make clear that the civil service medical benefits are not fighting resources for the general public. So if there is any remnant slots from the priority queue, it will be used by the general public. Do you have a blueprint to reach such targets? Well, to reduce the fight. Well, you are saying that you are setting up more such clinics if you find a good site. But from the statistics shown, once a family clinic is set up, the demand explodes.
For example, you will have Fanling and Sai Kung, and there will be 4 additional consultation rooms. And in future, the total number of attendances will change from 300,000 to 350,000. So your service must be good. So wherever you build a family's clinics there, civil servants will be attracted there. Just now we talked about Tin Mun Yuen Long, Tin Sui, and Dong Chong. There are big towns there, but there are no family's clinics. In the future, there will only be a Cheung Kwan O Family's Clinic, which is new. So this is a significant omission. So it's not a matter of choice. So I have these 2 questions. Who's going to answer the question? Thank you for your question. Well, for healthcare services for the civil service other than family's clinics, we are discussing with the HA as to how to provide specialty services to civil servants. For example, at Prince of Wales Hospitals and QM, now we have special services for civil servants that is also available at QEH. The HA has a 10-year hospital redevelopment program, and within those programs, we will designate certain services for civil servants. So other than building more family clinics, this is one more thing that we will do for the civil servants. So how about the development blueprints for the family's clinics? We now only see Cheung Kwan O family's clinics. So do you have a timetable for additional family's clinics? Now we only have Sai Kung and Cheung Kwan O in the pipeline. It seems that it's quite abstract. However, in new government buildings, we will try to identify sites for possible development of family's clinics. How about Dong Chong? The Lantau Bus Company has planned. Well, the Lantau Bus Company's bus depot is going to be redeveloped as a community service complex there. And do you have the number of civil service eligible persons? I have some figures. Up to the end of February this year, we have 554,000 civil service eligible persons. 172,000 of them are in service, and they include ICAC staff and from those in the judiciary, and also retired civil servants are included. 256,000 retired civil servants and eligible dependents. And for dependents, it means that spouses, etc. You are talking about ABCD, I'm talking about E. Please give me an answer for E. Well, the answer will be provided to you after the meeting. Dr. Kwok is not here. The remaining 3 members for second round questions are not here. Any other member would like to ask questions? If not, I will put this proposal to vote. We don't have a quorum here. Okay, let's ring the bell. Ring the bell. I think other members are not interested anyway. We have a quorum. Now let's put it to vote. For those in favor of the proposal, please raise their hands. Those against, please raise their hands. I think a majority of the members voting are in favor of the proposal. Do you want it to be voted on separately at the FC? Yes. I also have some questions. I'll give them to you later in writing. I would like to thank the 2 officers for attending today's meeting. Well, this has to be voted on separately at the FC. Okay, we move on to the next agenda item. Civil Aviation Department. Proposed creation of 1 permanent post of Chief Air Traffic Control Officer with immediate effect upon approval of FC, and 1 supernumerary post of Chief Air Traffic Control Officer D1 with immediate effect upon approval of FC up to the 31st of March 2025 in the Civil Aviation Department to strengthen managerial oversight of daily air traffic control ATC operations to ensure the provision of safe, reliable and efficient ATC services. On the 28th of May this year, the government consulted the Economic Development Panel of LegCo. In attendance, we have Mr. Raymond So, Undersecretary for Transport and Housing, Ms. Linda So, Deputy Director General of Civil Aviation, Mr. Raymond Lee, Assistant Director General of Civil Aviation Air Traffic Management, Ms. Mona Cheung, Chief Technical and Development, Civil Aviation Department. Mr. Chung Kwok-pan is the chairman of the Economic Affairs panel. He's not here at the moment, so I'll report on behalf of him. On the 28th of May 2018, the Economic Development panel discussed this item. Most members in general supported the proposal. During the discussion, some members thought that this 2 posts should be created as soon as possible because of the increased workload. One member thought that because the problem concerning airspace was not resolved yet, the supernumerary post responsible for the 3 runway systems can be created later. In order to enhance the public's confidence in ATC, the panel passed a motion urging the government to establish a notification system concerning major incidents. The reference information is in LegCo paper CB4 2017 bracket 01. 3 members would like to ask questions. First, Mr. Jeremy Tang. For this post, or these 2 posts, they should have been created early on. I would like to ask you, now you should provide me the information after the meeting. For CAD, and for those who are responsible for ATC, how serious is the overtime work? I believe that they have to work overtime all the time. This is very unhealthy. Of course, you say that they are frontline workers. However, they are the most important personnel. When an aircraft is flying, they are actually controlling the aircraft. So this is a pyramid. If you want to increase people, yes, I understand that you will be creating new posts, but you need to train them. So for this chief air traffic control officer, they also need to be undergoing trainings. So these two posts, they should have been created earlier. And for the post concerning the 3RS is about airspace. If you don't create this post, how can you negotiate with people about airspace? And for arranging approach and departure, you need people to take care of that. So it's really too late. Now you only create these two posts at the moment. And for the CATCO post, you have 3 chiefs. You have to look at approach, departure, transit flight, etc. How can one person take care of everything? And they are also positioned at different places. Some at air traffic control center, some at aerodrome control tower. Earlier on, you just have one chief ATCO. So it's far from ideal. And you should give me 2 pieces of information. First, airspace. Which stage is it at now? Second, for the front line ATCO, what's the overtime situation like? Who's going to answer this question? Thank you. As Mr. Tam said, we find the need to increase manpower to cope with the increased ATC demand. Previously, the overtime situation was pretty grave, but now the new system is in place, so the overtime situation has dropped. In 2017, it's 92 hours. How many hours? 92 hours. Every week? And then for duties, as Mr. Tam said, now we have one chief ATCO, and he's responsible for all ATC daily operations, including towers, terminals, approach, air routes, etc. So his workload is very heavy. In particular, our air traffic has increased by 40% in the past 10 years. That's about departing and approaching. And for overflight aircrafts, even more. So that's an increase of more than 100,000. So that's why we need another chief ATCO so that he can share the workload. With this new chief, the 2 units can be separated. So each chief will be responsible for 2 units. So in terms of efficiency and safety, we think a better job can be done. And secondly, about airspace, the governments of the 3 places have been liaising very closely. And now we are doing a speed test, and we are using a model to do that. So we are looking at the actual airspace condition with this test. We hope that in the coming year we can have an initial result, and then we can do better planning for the airspace. Now there are 4 units, and they are physically located at 2 places. So you need this post. You have been needing this post for a long time, and also the operation is now 24 hours. And also the 3RS is another problem. You don't have this post, you cannot be prepared for the 3RS. I know you are doing it, but how about the timetable? You have to give me the timetable in writing. When will the 3RS airspace problem be resolved? And for overtime, you also need to give me another paper. That is before the recruitment, what's the overtime level, and after the recruitment, what will the overtime level be? Mr. Wu Chiwai. I have two questions. According to the paper, with this new post, so for these ATCO establishments, there will be 524 officers. So if it's raised to this level, what improvements can be made to the overtime level? The manpower will be increased by 10%. And because of that, will the OT time be reduced by 10% as well?
If that is the case, do you have any plans to improve the OT overtime situation? As for recruitment and for training, do you have specific, clear targets? The level to be reached, because ATC is a very important element for air safety. So we hope to have more materials and information. Secondly, in order to renovate ATC system, you have obtained funding. You have now, when you have hardware and you add on software, do you have a clear timetable to show the traffic flow, the improvement of traffic flow of aircrafts, so that we can maintain our competition capability, that we can compete with other airports with improved hardware? Well, we should have enough flow of air traffic so that they don't go to land in other airports. Because once the flights leave base, they would not come back even if we have the 3 runway. Now, in order to improve the use rate of the airport, apart from the matching of hardware and software, do you have other ways and means to improve the flow of air traffic so that we can meet the competition from other airports in the area? Well, so that we can be capable of competing for flights and air companies that would like to land in our airport. Well, the Deputy Director General, for staffing and the problem of overtime, because we have a transfer to the new system, now we are now reducing the overtime with the new system, even though we have not increased the staff as of now. Now, we hope to release staff from overtime. Well, if we add posts, for instance, in 2018 and 19, we hope to recruit 42 ATC officers. If they can come in, they will increase our percentage by a lot. With this increase in staffing, we can hope that the overtime will be reduced. We don't have the specific figures. We are reducing it on one hand and adding posts on the other hand, and there's a trend towards the reduction of overtime. As for the equipment, for the landing equipment, or land-based equipment, we are talking about schedule up to 2024 to be ready for the 3RS. Finance Committee has given us some funding. We are talking about we're talking with air companies for equipment on board as well. At the end of the year, we will have a testing of our land-based equipment for the deployment of such equipment to accelerate the pace of our work in this area. Lastly, these techniques will help us to add to the capacity of airports, so that before the 3 hours, we can add to the capacity of our airport. Mr. Holden Chow. To create this post in preparation for the 3 hours and to monitor and oversee the functioning of the whole system, I support such a creation of a post. The 3 RS, according to what is expected. Now we know that with the two runways, we have 68 flights each day. With the 3 RS, by the year 2030, we will have 102 flights each day. I would like to ask, for the creation of this post, what is the assistance that will be given to the increase to 102 flights by the 2030? Would it be possible you will reach 102 flights before 2030? Well, since you have used a lot of resources for the 3 RS, we would like to have it go into its full potentials. So what is the situation as of now envisaged? Well, Deputy Director General, 102 flights is the ultimate target to be reached gradually. According to the overall plan we have now, we expect by 2030 we will have 607,000 each year, flights each year. This is the target volume, but of course we have to look into the situation when we reach there. These 102 is the ultimate target. We will increase our staff and adopt new technology so that we can reach the target set. A follow-up question. We have listened to the explanation furnished. Well, according to your assessment, according to your present assessment, would it be possible for you to reach 102 flights before 2030? We hope that the resources may be put to full use. Director General, yes, I quite understand. The 3 RS is set against the target of 102 flights. In order to meet the situation, the demands that we envisage, so we are going to meet the demands of 607,000 flights a year. There are 2 more members to raise questions. Well, we are going to extend the meeting by 50 minutes so that we can finish this item. Mr. Chung Kwok-ban, it is necessary to add a post, and I support it. Well, by 2030, flights will reach 607,000 flights a year. This Hong Kong and Guangzhou-Zhuhai Bridge is now being commissioned, and would it be possible that the airport might not be used to go to Guangzhou and Zhuhai? And the average increase is about 3.39%. So by 2030, the flights will be more than 600,000 flights. So with this the commissioning of the bridge, would it reduce the flights demand for the west of the Guangdong province? Well, the flow of the bridge traffic is more than envisaged. Have you taken into account the flow that would go to the bridge? The airport authority has made an estimation for the number of flights. I don't have the details of such an estimation. However, the bridge has just been commissioned, and we need to wait and calculate. And when we do further estimation, we would take into account of the bridge and to have more specific calculations. Well, we are now doing the preparation for hardware and software. We are deploying software, and if there are further demands in the future, we'll be able to meet them. The document says that the average flight increases by 3.39%, and if you do the whole calculation, it will be over 600,000 flights, the demand. So taking into account the bridge situation, we need to have another further assessment. Mr. Chen Chichun, in Enclosure 5, the 3RS, it will coordinate between submissions of operation requirements for preparing tenders of systems and equipment related to 3RS project and seek approval. This system will include the air traffic management, or does it include the radar system? If it includes the air traffic management and the radar system, can you promise that you will not repeat the thunder system? Now, have you learned from this failure, this experience failure? Can you tell us? Have you revised the purchase system so that you won't go exceed the budget or the for the 3RS project? Thank you. His duty in the FC meeting, we have a new control tower and the new platforms there, and new radars and designs and radars. We need to have air traffic controllers that have the relevant knowledge. And we went for funding from the FC. Now, we have already absorbed the experience obtained from the purchase made, and we have reinforced our measures. And in the tendering process, we have more market investigation. We have exchange experience with users in international meetings, and in tendering, we under appropriate situation. And if we buy complex technology, we will increase the technology ratio. we hope that such improvements would enable the process to be better implemented. It is not a matter of adding a post or not. In the past experience, we have spent the money. However, we had to be living in fear afterwards. So I think that staff concerned should learn from the past experience to work better. Right. Second round, Mr. Wu Jiwei. I'm now looking again at staffing. The ATC overtime is now 92 hours each week or each month. No, it is an accumulated overtime hours for each staff. What do you mean? What do you mean by accumulation?
I don't understand. So for OT, we look at it on a weekly or monthly basis. So is it 1 year or 10 years? It will give us a very different impression. So how long are they allowed to accumulate their OT time? We don't have a ceiling. Is accumulated. What I mean is that now on your record, how many OT hours you have. So it's not on a weekly or monthly basis. So it can be from a long time ago. So until now, each of them would have 92 OT hours on their record. So if that is the case, then you can make the calculation. Now you will have 40 more colleagues. So will the OT level drop significantly? I do not have the figures in hand because this is not a linear calculation. So maybe after the meeting, I can give you the relevant information. I'm worried that, well, safety is a very important issue for our international airports. Now, because of the shortage of manpower, many of the officers have many accumulated OT hours. Even with additional manpower, I'm afraid that they still have very heavy workload. So I'm worried about the shortage of manpower. And also in terms of training, can you ensure that the ATCOs can cope with the short-term changes? And in the long run, you may even need more trainings and manpower. So in this aspect, do you have plans concerning manpower so that we can ensure that there will be enough ATCOs when the 3RS is in place? Well, in terms of manpower, we have a plan. And for this plan, each year we will review it, and it is rolling. I can cite an example. In the past year, each year we will recruit 20 plus people, and this year it's been increased by 100% more than 40 new colleagues. So in the coming year, we will continue to recruit ATCOs. So we will continue to move in direction, and we hope that we can enough manpower in the future. Mr. Wu asked about recruitment and training. We have, after recruiting the relevant officers, we will start trainings right away. The trainings will take time. So it will take several years. So now we are recruiting newcomers, and we are doing our trainings already. So from now to 2014, can you give us a chart showing the milestones concerning manpower situation. Yes, I will do that. I will provide the answer in writing. Next, Mr. Adichu. Well, for the Chief ATO3RS, he will be responsible for monitoring the optimizing in the Pearl River, optimizing work in the Pearl River Delta. So I would like to ask the governments this. Now, for the airspace disputes about the Pearl River Delta, what are they arguing now, and what are the possible solutions? Because the public doesn't have the opportunity to hear a detailed explanation. And earlier on this year, Mr. Lam Chiu-ying from the former director of the observatory has shown us this chart. Now there may be 3 urinals in this photo, and if you place the 3 urinals like this, then it cannot accommodate 3 gentlemen at the same time. So this is like the airspace problem we are facing now. Is it really the case? Thank you for your question. Maybe I can give you some details concerning airspace. In 2007, the 3 governments, including the mainland governments, Macanese government, and us, we had already formulated a PRD airspace program. And at that time, we took into consideration all the major airports developments in the region, including the 3RS development in Hong Kong. And after that, the 3 parties continue to have meetings. We have been formulating details for different options. In the past years, we have achieved different goals. For example, in 2016, we had a senior exchange forum. Well, don't tell us about all this. Tell us what the problem is. Well, allow her to answer. I can allow her to answer, but now she's telling me what meetings she's been having. That's meaningless. I think you're most concerned about the airspace. Well, the aviation industry is developing very rapidly, and our neighbors are developing rapidly. So with such rapid development, it is hoped that all airports can give full play to their potential. So we are discussing all this, and up to now, in 2017, we conducted a study. We had a model, and we input data. We try to find out what the actual situation would be, and we will gather such data and details, and then we will have a clearer picture as to how to move forward. So now we have collected some more scientific data. So we hope that by next year we can have an initial result, and then we can move forward. Just now, Mr. Chu said that Mr. Lam Chiu-ying had a theory. That's an analogy. Do you think that analogy is wrong? In terms of airspace, well, it is a 3D dimension. It's not flat. It's not 2D. It's not like going to the washroom. So airspace is a 3D dimension. So for there can be different heights. Different heights can accommodate different aircrafts. So if it is 3D, it's more flexible. So if there's good coordination, and if everybody follows its flying protocols, then it should be all right. It's not comparable to a 2D dimension. So for the creation of these posts, well, this supernumerary post is up to 2025. So it seems that it's longer than other supernumerary posts. So you have to wait till the 3 hours is completed before this post is discontinued. Yes, you're right. This is to tie in with the timetable of the 3 hours. So if members have no other questions, then I will put this proposal to the votes. For those who are in favor, please raise their hands. Those against, please raise their hands. I think a majority of the members are in favor of the proposal. Do you think this should be voted on separately at the FC? Okay, thank you. What's the time of the next meeting? The next meeting is on the 21st of November, 8:30 a.m. Thank you.